invented devices in order to be sure that you are hitting the correct and the planned PTV. So that is the most important thing, and this is the key for the success of your treatment. I wrote here, no IMRT without IGRT. I always put this slide, and this is a message to everybody. There is no IMRT without IGRT. As if you don't use it, you may hit the organ address with the high dose and decrease much the dose to the prostate itself, and so you not only will get the biological failure, but you will get also with it an increase in the side effects. Furthermore, the IMRT allows a dose escalation because you are sure of your treatment, so you can increase the dose up to 80 and sometimes up to 81 gray. How we can do the IGRT? With the routine use, we either use the radiographic mode with the two orthogonal felts, and by with the machine you can calculate the correction that is needed in order to hit the correct PTV. The cone beam CT is done also by the radiographic mode, and this is or you can do it by fluoroscopic mode, as we will see later. Here is the OPI, which gives you the two images. Here, this is the one, and this is the two image, and of course the cone beam CT, either you get it according to the machine with the megavoltage image, or you will get it with the kilovoltage cone beam CT. Of course, the kilovoltage cone beam CT will irradiate the patients with less dose, and it will have a more clear picture or more clear volume that you will see the structures better than that of the megavoltage machine. Here is the cone beam CT to comparison between the kilovoltage and megavoltage, and in some cases there will be a CT simulation, on-ray simulation. Your patient will be put in the treatment position and then have a CT with a CT machine, and then if you are happy with this, you will transfer the patient in his own position into the linear actuator to receive the treatment. The tomotherapy is a good machine in which you have a CT and a linear accelerator in the same machine. So by this you can have the cone beam verification, and then you execute the treatment on the same position. This is the tomotherapy, and you have to adjust again daily according to the pictures that you will have. You can use the ultrasound but to verify the position of the prostate, and this ultrasound, there is a lot of work done, and there is many machines in the market that can give you the exact position, and within this exact position there is a threshold. If the patients or if the position of the patients exceed this position, the machine stops giving this. It's an intra-session correction. One of these are the clarity of the of Electa, and the fiducial marker. It's a new concept that because we are going the cone beam CT with which is not so clear. So we identified the prostate by the 3 fiducial markers, fiducial gold markers. That is one in the apex and 2 in the base. And then by this we are sure for each day that we are in position. Treatment identification either by fiducial, and the fiducial needs either the cone beam CT, EBID, or even the MRI, as we will see later. This is how the external beam is done with using the. This is a fiducial, and so we can be sure every day that we are within the same position and same thing. With the variant Calypso, they use the electromagnetic transponders in order to have the patient in position. Here we are in need of the fiducial again. And the advantage of this is we don't give X-ray in order to have a pictures, and because so we save the patient exposure to radiation. This is the you can do the electromagnetic tracking again by using the Calypso, as you can see it by Clarity with the ultrasound. And there is Linac-mounted system in order to correct for the position of the patients. There is a hexapod radiotherapy system in which the machine can be corrected in 6 directions, all the directions, including the tilt in each in the 3 directions. So that is can correct the position of the patient in order to give it with exact treatment. A good thing of the robotic tracking system using the CyberKnife, the CyberKnife is tracking the patients using a robotic arm as well as robotic table. And in this you can decrease the fractions of the of treatment from 38 fractions in order to few fractions like 6 or 8 fractions because of the very high accuracy rate. There is no isocenter, but there is a lot of so many thousands of isocentric for this CyberKnife. This is Clarity again, that it can be done. The new thing that there is nowadays an MRI guided radiation therapy. It's the linear accelerator provided. It is an MV machine provided with MRI. Why I say MV machine, because there are 2 types. Either they use the 3 cobalt sources with each with MLC and the 0.35 Tesla MRI in order to see the position of the patients correctly. And this is in the market right now. It's called ViewRay, and this is one paper about this is ViewRay MRI adapted radiotherapy. The other one is to use the linear accelerator. The problem with the linear accelerator is that the magnet will cause some deviation of the rays of linear rays, and they are working on that, and this is done nowadays, but it's not in the market yet by Electa. There is 2 projects undergoing now, one in Edmonton, UK, and one in Germany, that is, it will come soon. The dose escalation, the biologic model supports the dose escalation beyond 80. So we can go up more than 80 without much problem. Improved conformality and IGRT techniques allow it for the dose escalation. And there is a multiple randomized trial showing improved control rate with such dose. And to increase the accuracy, we can use the endorectal balloon, and they use the endorectal balloon, although it is not so popular as it has many complications in the isodose. The spacer to put iron days in between the prostate and the rectum is a good thing to protect the rectum from the high dose. And it was published that with the increase of the dose, you will get a lower prostate cancer relapse rate. As you can see here, the 82 is the lowest graph. And come to the proton therapy. The proton therapy is a very good machine, but it is very expensive and needs a lot of space in order to install. And this is it is either you use it as a passive scatter or by pencil beam scanning. And this is been going on right now, and the compact system of the proton therapy make it a little bit cheaper, and this made many of the centers are installing the proton right now. And thank you very much for your attention. Any questions? Okay, may I introduce my dear colleague, Dr. Ihab Khalil, to talk about the post-operative radiotherapy.
Thank you, Dr. Muhammad, for this concise and elaborate presentation about prostate cancer eradication and treatment verification. I think in the next coming, inshallah, I'll try to be fast in 20 minutes. بس استحملوني بقى, يعني you try to bear with me. That I'm going to be fast to work, to have hands-on much better. So the talk will be also concise and to the point. I'll try to divide the talk to partitions, the indications of post-operative, when to implement radiation early post-operative or defer till rising PSA, and the level of evidence about what we are saying. And finally, we'll show some delineation about the post-operative radiotherapy. So this is all only to show you that the prostate is insinuated between two moving organs, the bladder and the rectum, and the prostate itself is a moving organ because it's muscular tissue. This is to show you that the process of radiation therapy is a lengthy process. We play very much in the planning session, and then in treatment information, transfer, patient setup, treatment delivery, and Dr. Muhammad, of course, covered the treatment verification very well. And without verification, as Dr. Muhammad said, we cannot be sure what we are hitting. And there is a famous saying I usually put the dart picture in my talks, that if you not see what you're hitting, that you are not killing it. So you have to see what you are doing every day, and hence the verification becomes very important. By the end of the 90s, we used to use CT planning, and then MRI planning came over. Position verification is important, then IMRT. The problems is to visualize the targets and the normal tissues on daily basis, and correct for the movement, which is the intrafraction during the treatment, or the interfraction between day after day, and optimize the conformality by technique, which is the IMRT, IMPT, or proton therapy. What is the definition of a rising PSA after radical prostatectomy? Because the topic is after prostatectomy. So we are focusing that I'm having a patient who's coming after surgery. So the definition is the two determinants of a PSA more than 0.2 nanogram. Two successive rises of PSA means that we are having a failure. So if there is no evidence of disease and the patient is candidate for salvage therapy, then the patient should go for a dose 64 or higher. And the factors that are elicited, that is age, comorbidity, PSA kinetics, which is the doubling time, the Gleason score, the higher, the worse, and prognostic factors at original diagnosis. I will here stop. يعني اللي عايز يسأل لأن